Welcome to another lecture series by MedicoMedics. Pharmacology, Chapter 1, Introduction to Pharmacology. So in this brief introduction, we will begin asking the question, what is pharmacology? We will discuss its scope, history, classification of drugs, its nomenclature, routes of drug administration. We will introduce concepts like pharmacokinetics and pharmacodynamics. Now, pharmacology is the branch of medicine that studies drugs, their effects on the body, and the body's response to them. And we can divide it into pharmacokinetics, so what the body does to the drug, like absorption or metabolism is studied here. Then we have pharmacodynamics, so what the drug does to the body. For example, we study the mechanisms of action, its effects, etc. Now, when we look at the scope of pharmacology, key fields include clinical pharmacology, so application of drugs to treat diseases. We have toxicology, so the study of harmful effects of different substances. We have pharmacogenomics, so the role of genetics in drug response. And we have experimental pharmacology, so laboratory research to study drug effects. And what would be the application of all of these? Well, to develop safer, more effective drugs, to address challenges like antibiotic resistance. For example, pharmacogenomics helps explain why some people respond better to certain antidepressants than others. Now, taking a very brief look at the history of pharmacology, we have ancient times where natural remedies like willow bark were used for pain relief. We move into the Middle Ages. Here, mysticism turns into early scientific methods. We have people like Avicenna and his experiments with opium. And finally, arriving at the modern era with discoveries of synthetic drugs, antibiotics like penicillins, etc. Now, we typically classify drugs by four main criteria, either by source, by use, mechanism of action, or by system. So if we're talking about its source and we say that it's natural, it means we're talking about drugs that are derived directly from natural sources such as plants, microorganisms, or animals without significant chemical modification, like penicillin from mold. If it's semi-synthetic, like amoxicillin, here these are drugs initially derived from natural sources but chemically modified in the laboratory to enhance their properties, such as having increased efficacy or reduced side effects. Synthetic drugs like paracetamol. These are drugs entirely manufactured through chemical synthesis, with no direct natural source, designed to mimic or improve natural compounds. Then we have the classification by use. So if it's therapeutic, like antibiotics, these are drugs used to treat or manage diseases or medical conditions, alleviating symptoms or eradicating the underlying cause. Then we have by diagnostics. So for example, contrast agents. These are drugs or substances used to aid in the identification or visualization of diseases or abnormalities, often during imaging, for example, like X-rays or MRIs. And we have prophylactic, like vaccines. So drugs or agents administered to prevent diseases or infections before they occur, by enhancing, for example, immunity or reducing risk factors. We also have by mechanism of action, but this is covered in later slides and lectures. Finally, by system, so drugs targeting specific systems, whether it's the cardiovascular system or the nervous system, etc. Now, let's briefly take a look at drug nomenclature. So we have paracetamol. Now, that's its generic name. However, it goes under a different chemical name, so it's N-acetyl P-aminophenol, or however you pronounce that. it's typically not the name you would remember, memorize, or know about. Then it has a brand name, which is the official or the chosen name by the manufacturer for its marketing, which could be, for example, Tylenol. But the likelihood of going into a drugstore globally by just sheer chance asking for Tylenol, the chance is pretty low that they will actually know what it is, depending on which country you enter. But there is a great likelihood that if you say paracetamol, which is its generic name, they will recognize what you're talking about or what you're asking for. And I would say for your medical studies, the generic name is where you want to turn your attention. And then depending on which country you practice in, you will probably learn a couple of different brands for it. Now we can also take a look at two other examples like ibuprofen. It has a very complicated chemical name. No need to read it out. Same with diazepam. Looking here, it's even more complicated. And they go under different brand names as well. Like diazepam goes under Valium or Diastat, ibuprofen, Advil, or Motrin, for example. But I would say 99.9% of practitioners will know these generic names. And that's where you should turn your focus to. Now, we can't talk about drug administration without discussing its different routes. So how do we actually get it into our body? Well, there are several ways, all having different mechanisms as well. So it could be oral. Now, this is very convenient and easy. You just swallow a pill. But it's slower due to digestion. Then we have intravenous. So this is directly put into the bloodstream for rapid action. We have intramuscular, so we inject into muscles, offering an intermediate absorption. Then we have subcutaneous, so beneath the skin for slower, sustained release. And we have a lot of other different routes like inhalation, transdermal, topical, rectal, for example. And you can pause and take a look at the illustration right here, where we cover a lot of different routes. So the key point here is that not only that drugs can be, for example, injected, inhaled, absorbed through the skin, or swallowed as a pill, etc. But it's also important to remember that there are reasons for taking it differently. So the administration route also have consequences for how it's actually absorbed. We want it fast, we want it slow, we want it over time, etc. So different paths for different needs. Now, no course in pharmacology would be complete without a detailed study of pharmacokinetics. And studying pharmacokinetics helps us understand how a drug is absorbed, how it's distributed, metabolized, and excreted. So in other words, what the body does to the drug is what we're studying here. And this knowledge is essential for choosing the right dose, the right timing, and route of administration to ensure safe and effective treatment. For example, if you take oral ibuprofen, it's absorbed in the stomach and it's distributed via the bloodstream. Then it's metabolized by the liver and excreted by the kidneys. So it includes all key pharmacokinetic steps that determine how long and how strong its effect will be. So that's what we're going to focus on our coming lessons on pharmacokinetics. But pharmacokinetics is not enough. We also have another crucial and important concept, which is pharmacodynamics. And pharmacodynamics focuses on what the drug does to the body. So we've talked about how it enters, where it goes out, how it's metabolized. But what does it do to the body? How does it interact with our receptors, enzymes, our cells to produce its effects? And understanding this allows us to predict therapeutic outcomes, side effects, and how different drugs might interact at different targets. So central to it is, for example, the receptors, so proteins in the body that drugs will bind to for effect. And we have mechanism of action, of course, how a drug interacts with the receptors. We have agonist or antagonist. Does it block it or does it bind to it, leading to some effect? Another important concept is the dose-response relationship. So the relationship between the dose given and the effect. We have concepts like potency, so how much drug is needed for the effect, and efficacy, so the maximum effect a drug can achieve. If we go back, we had ibuprofen, right? We said that it was absorbed in the stomach, distributed through the blood, metabolized by the liver, and then excreted by the kidney. So it covered all pharmacokinetic steps. Now, if we look at it through the pharmacodynamic lens, ibuprofen works by inhibiting the so-called COX enzymes. These decrease prostaglandin production, leading to reducing inflammation, pain, and fever. And that's the pharmacodynamic effect. And as students, we have to keep both of these things in our head at the same time when studying medication or drugs, etc. How does it come in? How does it go out? What does it do during that span? Excellent. And that's the end of the first introductory lesson. Continue now to Chapter 2. Welcome to another lecture by MedicoMedics. Pharmacology, Chapter 2, Pharmacokinetics. In this lecture, we will talk about pharmacokinetics, discuss concepts like absorption, distribution, metabolism, excretion. We will take a look at pharmacokinetics in action and look at an example using ibuprofen. And then we will end with a summary. So pharmacokinetics is the study of how a drug moves through the body, often described as ADME. And the diagram here summarizes the 4 key phases of pharmacokinetics, known as ADME. So we have absorption, distribution, metabolism, and excretion. Together, these processes describe how a drug moves through the body from the moment it enters to the point it's eliminated. And understanding ADME is essential for predicting drug onset, intensity, duration, and safety in clinical use. So the diagram here illustrates the first step, which was absorption, which was the process by which a drug enters the blood from its site of administration. Now, after, for example, oral administration, the drug travels through the gastrointestinal tract and must cross several biological barriers before it reaches systemic circulation. Now, the path begins in the gut lumen, where the drug dissolves in GI fluids. It then passes through the intestinal epithelial cells via processes of passive diffusion or active transport. And this is often the rate-limiting step. Now, once inside the intestinal wall, the drug enters the portal vein and is then transported to our liver. In the liver, a portion of the drug may be metabolized, a phenomenon known as first-pass metabolism, which reduces the amount that reaches our systemic circulation. Now, the fraction that remains active is what's called the drug's bioavailability. So the factors affecting absorption include the drug's formulation, its solubility, pH stability, surface area of absorption, and of course presence of food or other drugs. And understanding absorption is crucial for selecting the correct route, dose, and timing of the medication. Now, once the drug has been absorbed, how does it then travel to its destination? So let's go and explore distribution. Now, after absorption, the drug enters the bloodstream and begins the process of distribution, meaning its dispersion into tissues and organs. Now, this will depend on several key factors. First one is blood flow. So, organs with high perfusion, like the liver and the brain, receive more drug more quickly. And the reason for that is because they have a rich vascular supply that delivers large volumes of blood per minute. Second one is plasma protein binding. So only the free, unbound drug can leave the bloodstream and exert an effect. Drugs that are bound to proteins like albumin, for example, they will remain inactive. Finally, tissue permeability. So lipid-soluble drugs can easily cross cell membranes, while water-soluble ones may be restricted. And a special consideration here is, for example, the blood-brain barrier, which protects the brain by limiting the entry of many drugs, making the central nervous system penetration more difficult unless the drug is specifically designed to pass through. And we have a whole dedicated lecture on different barriers, including the blood-brain barrier. Make sure you check that out. Now, once the drug reaches its site, it may need to undergo changes, and this is what brings us to metabolism. Now, metabolism refers to the chemical modification of drugs, usually occurring in the liver. And it is to make them easier to eliminate from the body. Now, it happens in two main phases. Phase 1 involves modification reactions like oxidation, reduction, or hydrolysis, which introduce or expose functional groups. These reactions are primarily carried out by cytochrome P450 enzyme system, often abbreviated as CIP enzymes. Now, phase 2 is conjugation, where the drug is joined with a water-soluble molecule, like glucuronic acid, for example, making it easier to excrete through urine or bile. Now, an important concept here is the first pass effect. So, drugs taken orally must pass through the liver before entering the bloodstream, and a significant portion may be inactivated during this first pass, leading to a reduction in its bioavailability. Now, after metabolism, the body needs to get rid of the drug, so let's look at excretion. And now we arrive at the final phase of pharmacokinetics, excretion, the process by which drugs and their metabolites are removed from the body. Now, the kidneys are the primary route of elimination, especially for water-soluble drugs. These are filtered into our urine. Then we have the liver. So the liver also plays a role by excreting some lipid-soluble drugs into bile, which are then eliminated in feces. Other less common pathways include the lungs, for example, for volatile drugs like anesthetic gases, as well as sweat and saliva are some of the other routes here. Now, a key concept in relation to excretion is the concept clearance. It refers to the rate at which a drug is removed from the body. It directly impacts the drug's half-life and helps determine the appropriate dosing frequency to maintain therapeutic levels. Now, what is half-life? Let's move to pharmacokinetics in action and see what it is. Now, to finish, let's apply pharmacokinetics to real-world prescribing. Two key concepts here are half-life and steady state. Now, a drug's half-life is the time it takes for its concentration in the blood to drop by half. This directly determines how often we need to give a dose. The steady state concentration is reached when the rate of drug intake equals the rate of elimination. So it's a critical concept in long-term therapies where stable blood levels are needed. For example, drugs with a short half-life, like paracetamol, requires more frequent dosing, while those with a long half-life, like amiodarone, can be given just once daily. Understanding this helps tailor dosing regimens to maximize effectiveness and minimize toxicity. Now, let's summarize all 4 key steps in pharmacokinetics using the drug ibuprofen as our example. So at the very start, after swallowing, ibuprofen dissolves in the stomach, mostly absorbed in the small intestine. Now from there, it enters our bloodstream through the portal vein. So it's been absorbed now. Then we have distribution. So once in circulation, ibuprofen is extensively bound to plasma proteins like albumin. And then it is distributed to inflamed tissues, joints, and muscles. Afterwards, in the liver, ibuprofen undergoes phase 1 oxidation via the P450 system, mainly CYP to C9. This will convert it into inactive metabolites. These metabolites then are conjugated in phase 2, making them water-soluble. And so now the water-soluble metabolites are then primarily excreted by the kidneys in urine. Now, because ibuprofen has a relatively short half-life, approximately 2 hours, it needs to be taken multiple times a day to maintain its effect. So in summary then, we discussed the concept of absorption, the entry into our blood, distribution, the delivery to our tissues, metabolism, the transformation in the liver, and finally excretion, so the elimination via our kidneys or bile. Why is all of this clinically relevant? Because it helps us optimize dosage, avoiding toxicity, and ensuring effectiveness. Next, we will explore pharmacodynamics to understand how drugs produce their effects. And that's the end of the lecture. Please continue to Chapter 3. Welcome to another lecture by MedicoMedics, Pharmacology, Chapter 3, Pharmacodynamics. In this lecture, we will begin with an introduction to pharmacodynamics. We will discuss important concepts like mechanism of action, drug-receptor interactions and relationship, types of drug effects, variability in drug response, and as always, end with a summary. Now, pharmacodynamics is the study of how drugs exert their effects on the body. And we will cover 3 main areas here. We will discuss mechanism of action, dose-response relationship, and therapeutic and toxic effects. Now, the mechanism of action describes the specific biochemical interaction through which a drug produces its effect. Now, drugs can act in a variety of ways, either through receptor binding, for example, as an agonist or an antagonist, such as those targeting G-protein coupled receptors. We can have it through enzyme inhibition, like ACE inhibitors, used in treating hypertension, for example. There is ion channel modulation, as seen with calcium channel blockers, or by blocking transporters such as SSRIs, in treating depression, for example. Now, drugs also differ in target specificity. So selective drugs, act on specific targets and typically have fewer side effects, while non-selective drugs may act broadly across systems, increasing the risk of adverse effects. Now, once a drug binds to its target, it can initiate downstream effects like signal transduction cascade, for example, gene expression changes, or altered cellular function. As a classic example here, illustrated in the image, is the action of selective serotonin reuptake inhibitors. So normally serotonin, also written out as 5-HT, is released from the presynaptic terminal here, right? And when it's released, it binds to postsynaptic serotonin receptors. And it is then taken back up by serotonin reuptake transporters, seen here. Now, the SSRI blocks this transporter. So this will then prevent the reuptake of available serotonin. And the result of this is a therapeutic antidepressant effect. And it's achieved by modulating neurotransmitter levels without introducing a new neurotransmitter. We are just prolonging the action of the body's own serotonin. And we have detailed lectures on the mechanisms of SSRIs and other antidepressants and drugs used in psychiatry in our other lessons. Make sure to check those out. Now, moving to another important and fundamental concept is drug-receptor interactions. It describes how drugs exert their effects by binding to specific receptors or proteins that initiate a biological response. And these receptors can be ion channels, enzymes, G-protein coupled receptors, etc. Now, drugs can act in different ways. So we have, for example, agonists. These bind and fully activate the receptor, producing a physiological response. An example is albuterol, a beta-2 agonist. And what it does is it stimulates bronchial receptors to open airwaves. And we use it in treating asthma, for example. So agonists activate receptors to produce a full response. Then we have antagonists. These bind, but they do the reverse. They block the receptor, preventing activation, seen here in this illustration. And an example of an antagonist is propranolol, which is a beta blocker. And what it does, well, it's given in the name, right? It's a beta blocker. It prevents adrenaline from stimulating the heart, leading to a lower heart rate and lower blood pressure. Usually it's used in treating hypertension, for example. So that's the main thing to take here. Agonists, they activate receptors to produce a full response. And opposing to it or contradicting it is the antagonists. They also bind to receptors, but they block activation. Now we have something in the middle, which is partial agonists. These activate the receptor, they bind to it and activate the receptor, but they elicit only a submaximal response. So it's less intense. An example is buprenorphine. Creates a partial stimulation of opioid receptors. So it leads to providing a pain relief with a lower risk of leading to respiratory depression, which is something that's always considered. Now we arrive at dose-response relationship. Now, the dose-response relationship describes how a drug's effect changes with increasing doses and is typically illustrated in 3 phases. So phase 1 shows little to no effect due to subtherapeutic dosing. Phase 2, however, reveals a steep increase in drug response with rising doses. This is where the drug is most effective. And phase 3 is the plateau, where increasing the dose further produces no additional benefit, indicating that maximum efficacy has been reached. And then we have 2 crucial concepts here: potency and efficacy. So the potency of a drug refers to how much is needed to produce a given effect. So a more potent drug reaches its effect at a lower dose. And if we look at the illustration right here, the concept of potency is clearly illustrated in our curves here, where the ED50, so the effective dose for 50% response, indicates potency. In contrast, TD50 here, or a toxic dose for 50% response, represents the onset of toxicity. And the therapeutic index, so the distance between ED50 and TD50, seen here, clearly illustrated, reflects the drug's safety margin. So a wide therapeutic index means that the drug can be administered safely over a broader dose range, while a narrow index requires precise dosing and close monitoring to avoid toxicity. Now, drugs can produce a range of effects in the body, and understanding these is essential for safe and effective clinical use. So, what is the therapeutic effects of a drug? These are the intended beneficial outcomes, such as pain relief from opioids, for example, or blood pressure reduction from antihypertensives. So this is the kind of result we want. We give this drug with the therapeutic effect being lowering blood pressure, for example. However, not all drug effects are desirable. So even if our aim is to reduce blood pressure, we also have to deal with adverse effects. And these are the unwanted side effects that can range from mild to severe, and they often accompany therapeutic use. So they sort of go hand in hand. And the idea is to minimize adverse effects while maximizing therapeutic effects. Now, some of these are dose dependent, meaning they become more likely or more severe at higher doses. For example, liver toxicity with doses of paracetamol. And why is that happening? Because at therapeutic doses, paracetamol is safely metabolized by the liver. But in overdose, the normal pathways become saturated, leading to accumulation of a toxic metabolite that will deplete glutathione and causes hepatocellular damage. Others are idiosyncratic, meaning they are unpredictable and not related to dose or known drug action, such as an allergic reaction to penicillin, for example. And then finally, we have toxic effects. Now, toxic effects occur when a drug is taken in excessive amounts and over prolonged periods, leading to harmful outcomes like organ damage or systemic toxicity, etc. So recognizing these different categories helps clinicians anticipate risks, tailor dosing, and monitor patient safety. Now let's take a look at how drugs vary in their effects across different people. Now, drug responses can vary between individuals, and understanding the factors that influence this variability is crucial in clinical practice. So, what are some of these factors that affect drug response? Well, one of them is genetics. It plays a major role. Some patients are fast or slow metabolizers due to inherited differences in enzymes like CYP450, affecting how quickly a drug is broken down, for example. Another important factor is age. It also matters because, for example, infants have immature liver and kidney function, while the elderly often experience reduced organ function, both of which can affect drug clearance. Another factor is disease states, so particularly liver or kidney dysfunction. It can impair drug metabolism and excretion, leading to accumulation and increased risk of toxicity. Additionally, drug interactions can modify effects. Some drugs may enhance or synergize. Others may inhibit, antagonize each other, altering efficacy or safety. A classical clinical example is warfarin, where dosing must be adjusted based on genetic variants in the CYP2C9 enzyme. This enzyme influences how quickly the drug is metabolized. So understanding these variables helps personalize therapy and, of course, minimize adverse outcomes. So in summary then, in the lecture we covered mechanism of action, which describes how drugs produce effects via receptor binding or enzyme inhibition, ion channel modulation, or transporter blockade. Further, we discussed drug receptor interactions. This included agonists that activate, antagonists that block, and partial agonists with weaker activation. And of course, that receptor type will determine the response. We then move to dose-response relationship. So drug effects increase with dose until we reach a plateau. And key terms here included potency, so the dose needed, and efficacy, the maximum effect. And finally, we had drug effects and variability. So effects may be therapeutic, adverse, or toxic. And responses may vary due to genetics, age, disease, and drug interactions.